First of all, it's an absolute privilege to be here. And from my point of view, being from Ireland, we share the same colours as the Indian flag. So other than the one time that we beat you in cricket, which will probably never happen again, it's a great privilege to be here. But all the more so to be part of this fantastic innovation program. And I'm indebted to Dr. Rajiv Modi for his inspiration and kindness, and for the great opportunity to come and talk to you about pulmonary hypertension this evening. So if I could have the first slide up, please. We heard earlier that pulmonary hypertension is something that is important in thoracic medicine. And of course, often when you go to lectures, the last thing you want is to see a slide with loads of things written on it, because it puts people to sleep. And I apologize if this does the same. But if you look at this slide in particular, you can see that there are lots and lots and lots of disease processes that are involved in this concept. And I remember one of my early teachers in the Brompton Hospital saying to me that when she did anatomy, the heart was connected to both lungs. And now with super specialties, we often forget the basics. And pulmonary hypertension is one area in medicine that encourages us to go back to the basics. And as you can see from this slide, there are lots and lots of different disease processes that can give rise to pulmonary hypertension. And it's for this reason that many of you in this audience will be familiar with a variety of these conditions. And a lot of the time, when patients with these conditions are not actually responding to treatment, often the reason that they're not responding to treatment is not because of their primary disease, such as COPD or lung fibrosis or other conditions or cardiac failure with left atrial hypertension, but it's due to the consequences of that disease process, which is pulmonary hypertension. So you can see here, for example, that for groups, and currently in the United Kingdom and around the world, the majority of diseases listed in class 1, group 1, you can see on the slide there, the first one on the left, are the ones that are receiving advanced targeted therapy. And the reason that they are receiving advanced targeted therapy is that there is evidence that targeted therapy is beneficial, and we'll talk about that in a little while. But something that perhaps isn't very obvious is that despite the fact that these conditions are apparently very different, congenital heart disease, cirrhosis of the liver, HIV infection, connective tissue diseases, but they actually all share the same histopathological appearances, which nobody really at this stage knows why that happens. And it often invokes one of my favorite quotes from research, and I'm sure Dr. Rajiv Modi and his dad were very familiar with that, and they were the words of Louis Pasteur, who said that in the field of human observation, chance favors the prepared mind. And I think there are lots of lessons in pulmonary hypertension that we can learn, but we're just looking for that little spark to bring those together. So what do we mean by pulmonary hypertension? Well, we actually mean that a patient has a mean pulmonary artery pressure of 25 millimeters of mercury at rest. And the normal pressure is about 12 plus or minus 2. So it's approximately twice normal. But it's still try and be aware of this as a diagnosis. And one of the things that we're doing at our hospital is not only setting up study days and trying to promote research and publish papers and present at scientific meetings, but also go out into the community and set up nursing study days. And I gather that Dr. Modi and his group had one in Ahmedabad over the last couple of days for nurses. And this is the sort of thing that we're doing for our nurses in the region to improve their awareness of this condition. And what actually happens with this condition is that because you get progressive obstruction of blood vessels, the actual blood vessels get progressively obstructed with this proliferative change, despite the diverse etiology of the conditions that I mentioned. And ultimately, the resistance to blood flow goes up. And the concept that we measure is a thing called pulmonary vascular resistance. And for those of you who are interested, it's calculated by measuring the mean pulmonary artery pressure, taking away the left atrial pressure, and dividing it by the cardiac output, a kind of plagiarization of Ohm's law of electrical circuitry. So as the PVR, or pulmonary vascular resistance, rises, the blood flow through the lung goes down, the cardiac output, and the patient gets more symptomatic with breathlessness, and ultimately right heart failure supervenes. But interestingly, as you can see from these slides, you have relatively no change up at the top here in terms of blood vessels, and you get a degree of vasoconstriction, but ultimately you end up with this, where the actual blood vessels are completely occluded. And that's mirrored by an echocardiographic finding which shows that the right ventricle, which is this here, is very dilated. But a pitfall that people fall into, and this is really important if these patients are going to have surgery, is that if you measure the pulmonary pressures towards the end of the disease, they may be relatively low, reassuringly low in a false way, because the blood flow or cardiac output through the lung is very, very diminished. So one of the things that we're pushing very hard on diagnosis so that we can diagnose and treat these people before vascular remodeling has occurred. And the first symptoms are often very non-specific. And interestingly, we thought originally that the incidence of this condition was very rare. In the United Kingdom, maybe 3 or 4 per million. But now, when you look at all other diseases, the incidence is probably more than 200 per million. So this is a big condition of diverse etiology. So the first symptoms would be perhaps a little bit of stress-induced breathlessness or chest pain, working all the way through to end-stage right heart failure. And unfortunately, at the present time in the Western world, by the time the majority of patients are diagnosed with this condition, their median life expectancy is less than 3 years. So this is something that we are stressing aggressively to try to improve diagnosis and treatment. So why is it a devastating disease? Well, it's an orphan disease, and still a lot of my colleagues are still not thinking about this condition. I was very upset a while ago when we were talking to people engaged in cardiothoracic medicine in a London hospital, a well-known London hospital, and there were 70 trainees in cardiology, respiratory medicine and cardiac anesthesia, and only 4 of those trainees knew what the normal mean pulmonary artery pressure was. So really it is very important for us, at least in cardiothoracic medicine, to go back to the basics, because a lot of people don't know the basics. And we always promote the concept that those people who do extraordinarily well are not the ones that know the extraordinary, but rather they know the ordinary things extraordinarily well. And that's something we keep reinforcing. So it's a disease with a poor survival, poor quality of life. It has very limited treatment options, although these are now expanding and have expanded dramatically over the last few years. And at the present time, it would appear that there's no cure, although we can certainly stabilize many patients and retard the rate of progression. And the understanding of the disease is improving all the while. Now, if you just look at survival, these are 2 curves which show the survival in the different classes 1, 2, 3, and 4. So class 4 would be NYHA class 4, meaning that patients are bedbound or wheelchair bound. So they've got a very, very limited capability with regard to oxygen utilization and exercise capacity. And you can see that these people have a very, very short life expectancy. But median time to diagnosis and death is about 2.8 to 3 years. So early diagnosis before vascular remodeling has occurred is mandatory. Now, this just shows you in the Western world the actual survival put in the context of commonly encountered malignancies. And you can see that when you look at lung cancer, breast, prostate, colon, stomach, in these slides here, those patients with class 4 pulmonary hypertension do worse. So it is a disease that warrants urgent assessment and intervention. And for those of you involved in conditions, for example, connective tissue disease, if you have patients with scleroderma with no pulmonary hypertension, which is the yellow here, and then you have lung involvement, you can see that the survival is reduced. But if those patients with scleroderma also have pulmonary hypertension, the survival is dramatically reduced. And of course, a lot of people, if their patients aren't responding, they assume it's lung fibrosis or something. They forget about the fact, as I said earlier, without patronizing anybody, but the actual heart is connected to both lungs, and people forget about that. And we super specialize as pulmonologists or cardiologists, and even within cardiology, valve people, electrophysiologists, left-sided people, mitral valve people, interventionalists, and so forth. And we need to just take a little step back to go forward, because after all, research is derived from the concept of re-looking at other people's work, searching through previous work, looking for clues. And I was very impressed at the video early on, looking at some of the great titans in medicine, that people actually made great strides and achievements, and we stand on their proverbial shoulders. And I think a lot of those, and we heard about Jenner and Hounsfield among others, were people from the UK that we grew up with in terms of our medical training, in terms of the knowledge and teaching that was passed down to us. And this was, sorry, I should just go back, this was just looking at people with HIV, and again, for reasons that are not clear, if you have HIV and you get pulmonary hypertension, you will get the same histopathological changes in the lung as you would do in somebody who gets pulmonary hypertension associated with an ASD or a VSD or hepatic cirrhosis or idiopathic or slimming pills. And the reason for that is far from clear, and yet those people who get pulmonary hypertension due to COPD or lung remodeling or left heart failure do not get the same vascular remodeling. It's different. So again, this is something that presumably will stretch the field over the coming years, but perhaps the lung has only a finite way of responding to insults. So for example, we know that there's over 120 different causes of ARDS, but actually the end result histopathologically and the pathobiology is very similar regardless of the cause. Likewise, if you get obliterative bronchiolitis after lung transplantation, that appearance is the same as the obliterative bronchiolitis you see in children with respiratory syncytial virus or people with rheumatoid disease. The histopathology is the same. And in HIV, we know that pH is a factor that increases mortality, and often it's not looked at until the disease is advanced. So the prognosis is dependent on the etiology to a degree, and obviously early diagnosis will improve the WH class that we diagnose it at, and we do that very simply. We just do an unencouraged 6-minute walk test. It's a very, very, very reliable way of looking at exercise capacity in these patients, because we don't want to push them, because if we push them, their pulmonary vascular resistance can increase, and as a consequence, they can get cardiac arrest as a result of poor perfusion through the lungs and inadequate left atrial filling. The hemodynamics, we look at echo, and in our unit we perform a lot of right heart catheterization. And it's funny how these conditions have developed over the years. When we started, I remember being moved not by any of the great people we heard about at the video at the beginning, but rather a Kevin Costner movie called Field of Dreams, and it was about this man building a baseball field in the middle of, I think it was Nebraska. But the actual theme going through the movie was, if you build it, they will come. And we applied this to our large airway intervention program at St. George's. We were initially told we could do 12 patients a year. We had done 12 in the first month, and now it's the biggest service worldwide for that form of intervention. So it's the can-do mentality which is essential. So this is how we make our diagnosis and indeed study the prognostic factors in our patients. And just looking at quality of life, if you compare the quality of life to other conditions such as COPD, for example, or patients who have end-stage renal failure, or patients who have pulmonary hypertension, you'll see that looking at those, the impact on quality of life is comparable. So a lot of the time, these people have poor quality of life because the condition is not diagnosed. And that's something that we need to improve on. So, in terms of the treatments available and where are we going, well, we've got oral agents, we've got intravenous agents, subcutaneous agents, and nebulized therapies. And those drug armamentaria are increasing over certainly the last few years, and there's new agents coming out on the market over the next 6 to 12 months. For those patients with end-stage right ventricular failure, perhaps as a bridge to transplantation, you can perform right atrial septostomy, which is, if you like, a variant of the old Rashkind procedure, looking to try and offload the ventricle by letting blood shunt purposefully through the interatrial septum. And in patients with pulmonary hypertension, as a really end-stage maneuver, that is a possibility. And of course, transplantation is still on the cards, but for selected patients only, and that condition is limited by the very limited availability of donor organs, and the well-known late complications of immunosuppression and chronic lung rejection, which is obliterative bronchiolitis. Okay, well, what are the treatments that we can give? Well, some patients will respond to calcium channel blockers. It's only a minority, 5 or 10%, but some do. And when we're performing right heart catheter on these patients, we give them a vasodilator response using usually prostacyclin or sometimes nebulized nitric oxide. And we measure their PA pressure and cardiac output, and we define a response as a greater than 30% reduction in mean pulmonary artery pressure and an increase in cardiac output. Some patients respond to calcium channel blockers, but the majority will not. Okay. In terms of transplantation, well, the numbers for that have fallen off dramatically, but the actuarial survival at 3 years is probably in the region of 60%. And obviously it's a very expensive treatment, and there are lots of other factors that would influence transplantation when you're considering it for patients with pulmonary hypertension. And obviously I'm very happy to talk to people afterwards if they wanted to discuss that. What do we understand about this disease? Well, we know that for the majority of patients in group 1, which is where treatment is currently being focused, that apparently disparate group of patients with ASD, VSD, patent ductus arteriosus, slimming pill ingestion, SLE, HIV, idiopathic slimming pill ingestion, and so forth, all of those patients share the same pathological homology, and that homology is vasoconstriction, and then cells, myofibroblasts, from the inner half of the media of the blood vessel actually migrates into the lumen, and it proliferates around so that ultimately it looks like an onion. And because it looks like an onion, imaginatively, it's known as onion skin proliferation. And as a result of that onion skin, the radius gets less and less and less. And ultimately, as you can see here, there's little or no radius in the vessel at all. And as we know, the flow through the blood vessel is proportionate to the 4th power of the radius, if we believe Poiseuille's law. And as a consequence, as the radius gets smaller and smaller and smaller, the resistance to flow gets greater and greater. So what we want to do is diagnose the disease early before vascular remodeling has occurred. But when these blood vessels get obliterated like this, proximal blood vessels at points of branching, they rupture and the patient experiences hemoptysis. And then primitive blood vessels grow like a meshwork of grapes, a plexus, an abnormal meshwork. And that concept where you get blocked blood vessels and plexiform change is known as plexogenic pulmonary arteriopathy. And why it's peculiar for these diseases that seem very, very, very different is still poorly understood. Nevertheless, in what's available, we do know that there are lots of factors that are involved in the process. And we do know that in the lung circulation, and I dare say in many other circulations, that there is a dynamic second to second, millisecond to millisecond secretory arrangement from the endothelium, the largest percentage of which in the body is in both lungs. And we're constantly releasing pro-dilatory and pro-constrictory factors, prothrombotic and procoagulant factors, and a variety of other chemotactic factors that are designed to constantly change the caliber of blood vessels and promote fluid coagulation without causing any adverse impacts in proportion to infection, in proportion to activity or other pathology like heart failure. And the great thing about this is that overproduction of some of these factors is being identified. For example, overproduction of endothelin-1. And endothelin-1 acts on a receptor, the endothelin receptor, A and B, and that causes vasoconstriction in the lung blood vessels and also proliferative change. So a lot of drugs are now being developed to go against endothelin receptors, the so-called ERAs or endothelin receptor antagonists. And they will block either endothelin A and B or endothelin A receptors and offset the consequences of overproduction of endothelin in a pathological environment. However, what causes that overproduction to occur is still not clear. Other agents that we give are agents to replace nitric oxide because a variety of conditions lead to depletion of either L-arginine, which is the substrate for nitric oxide, or indeed other aspects of the nitric oxide pathway, nitric oxide synthase and other parameters. And as a consequence, nebulized nitric oxide therapy is a possibility. Other agents are focusing on phosphodiesterase inhibitors, and of course there are two PDE5 rich sites in the body. One is the urological tract, particularly in males, and the other is in the lung circulation. And obviously we all know what Viagra, sildenafil does, but in terms of the lung circulation, it is a very good pulmonary vasodilator, and it is used readily. And I'm sure you've all had compliance issues with your drug trials, but I can tell you that for us, we've never had any compliance problem among our men taking Viagra. Still haven't worked out why that should be. Prostacyclins are other areas that we're looking at, and there's oral prostacyclin analogues coming out later this year, but constantly they're being given at the present time via the intravenous route. And then other agents can be given subcutaneously. But the research at the present time has focused up until now on phosphodiesterase inhibition, endothelin receptor antagonism, arachidonic acid metabolism derangements, i.e. prostacyclin, and nitric oxide issues. So that has been the main armamentarium to date. And this just shows you a slide, and the kind of orangey color that you can see evidently around the blood vessel is just a marker for endothelin-1 to show you that in pathological changes, this is the plexogenic change that I mentioned, you get richness of endothelin-1, which is abnormal. We do see some families with this condition, and for those of you who've treated patients with emphysema, you'll be familiar with patients who have alpha-1 antitrypsin deficiency, and you'll be familiar with the fact that that is a housekeeping enzyme, and you'll be familiar with the fact that you can get a lot of infection and damage as a consequence in these patients, giving rise to particularly basal cystic change. In pulmonary hypertension, genetic studies have shown in some patients that there is a deficiency of a thing called BMPR2, and basically what that is, it's what we call bone morphogenetic protein receptor type 2, and you might say, well, so what? What's the big deal? Well, that receptor is very important at regulating vascular proliferation in the lung. So if you have, for example, any condition that causes vasodilatation or lung injury and you want to heal in that area, then BMPR2 regulates that. And people who have problems with that receptor at varying different levels aren't able to regulate regrowth. So they get overproduction of vascular endothelium and fibrosis in response to injury. So there are a variety of different abnormalities, but it's really just to focus on that as another avenue of research. So before we end, what are the current thoughts? Well, the current thoughts, and I wanted to distill this down for you today, in terms of pulmonary hypertension, what do we think the main issues are? Well, we believe that the majority of patients will have genetic predisposition. It may be problems with the enzyme pathways that I mentioned that are located on the endothelial structure, or it may be that they've got genetic issues, for example, problems with production of this BMPR2. That's certainly increasingly becoming available. Then, in addition to that risk factor, patients develop an injury, for example. They get exposure to toxins, they develop or acquire an autoimmune disease, they develop an infection, for example, with HIV. And as a consequence, those two combine together to give you a vascular injury. Now, as a consequence of that vascular injury, a variety of things happen. Endothelial cell dysfunction is known to occur, as is smooth muscle cell dysfunction. And as a consequence of that, there is an inflammatory change. And the environment, the vascular endothelial environment, the change, the milieu, is altered. And as a consequence, you don't have the normal variation in these things which closely regulate vasoconstriction, vasodilatation, prothrombosis, procoagulation. That balance is lost and abnormal changes occur. And that gives rise to the proliferative changes that we observe in the disease. And this is just showing it at different levels. And there are a variety of new agents coming through. People are looking at the effectiveness of statins. They're looking at various different monoclonal antibodies against different complement activated products or different interleukins. And these are things that are emerging and perhaps may be of benefit in the future. So, just to end, and again to thank Dr. Rajiv Modi for this privilege to come to participate among such a fantastic faculty as you have not just here but all around India this weekend and next. But to end, pulmonary hypertension, if there's one lesson I'd like to get across, if we forget everything else that has gone before, it's just please consider it. It's not some esoteric disease that's, if you like, picked up by people who have a specialist interest. It's a common accompaniment of many commonly encountered cardiac and respiratory diseases. And often, those people with those diseases don't respond because we forget that the pulmonary hypertension is an important factor in their symptomatology. So that would be point number one. Point number two is please consider it early because it is a progressive and lethal disease. The initial symptoms are very non-specific and people are often labeled as having depression, so beware of that. If in doubt, contact colleagues who are specialists in the area and consider the basic investigations that we have said. And although there is a limited understanding about this disease, things are improving dramatically, and certainly over the last 5 to 10 years, there's been an exponential rise in our awareness, diagnosis, and therapeutic strategy. And I think it's a very important thing to be aware of and not to be despondent. So I'd like to end by saying thank you for your interest in this, and thank you to Dr. Modi for the privilege of being here.